CCS Cases Review Part 1. Thank you to Dr. Ujjwal Soni for compiling these notes. Let's begin. The basic things that we have to note in the question stem of the CCS cases is number 1, age, number 2, gender, number 3, social status regarding alcohol, smoking, and sex, and number 4, vaccination status. Why we need to keep these things in mind? So that we can come to an appropriate diagnosis considering the age and the gender and the social and the vaccination status, so that we can address these at the end of the case regarding alcohol advice or smoking or sex advice, as well as give the appropriate vaccinations. In the physical examination, if the patient is unstable, we will do a focused examination, whereas if the patient is stable, we will do a complete examination. Now come the emergency orders. I have divided the emergency orders into A, B, C, and D. So first of all, if the patient is unstable, it's very important that you make sure that his vitals are okay. So in order to ensure that his vitals are okay, you need to do pulse oximetry and ABGs just to find out that his saturation is good and saturation is good and there is no acute acid base abnormality. Similarly, cardiac monitor to look for the cardiac status and blood pressure monitor. So first of all, in step A, for a person who is unstable would be oximetry, ABGs, blood pressure monitor, as well as cardiac monitor. Secondly, after we have done these and ensured that the patient is actually stable, doesn't need oxygen or any acute intervention, then we are going to do a focused physical examination. So that's step B. And after doing the focused physical examination, then we are going to administer the appropriate things. For example, like the appropriate emergency orders, which will include oxygen if the saturation is low, IV access, of course, if you want to draw blood or if you want to give some medicines, and along with the IV access, we can do a random blood sugar testing as well. And regarding, since the patient is coming in an emergency, if there is some cardiac or chest cause, then we will do cardiac exams and EKG. So a quick review of the orders that we are going to do in emergency would be A, B, C, and D, and we can make them in the form of a step ladder pattern, that we will do this step ladder pattern of A, B, C, and D orders. So let's begin. First of all, for the A orders, we will do pulse oximetry. We want to ensure that the patient's oxygen saturation is good, along with ABGs. Then along with this, we are going to do blood pressure monitoring as well as the cardiac monitoring. This is step number A. Once the patient is through step number A, we are going to go to step number B, which is basically doing a focused physical examination since the patient is still unstable. Physical exam. Next comes step C, which is to take care of the ABCs, which include oxygen, IV access. Along with the IV access, we can also do a random blood sugar just to ensure that the patient is not hypoglycemic or hyperglycemic and the glucose is not causing any abnormalities. And then if the patient has some chest or cardiac cause, which can be like an emergency or acute situation, then we will do an EKG along with EKG along with cardiac enzymes. Cardiac enzymes. Okay, so these are the emergency orders that we are going to do. Next come the lab studies. So the general lab studies, in case you don't remember what to do specifically in any situation, you can just write these lab studies on a piece of paper or memorize them, and then you can pick and choose from these according to your particular patient and according to his symptoms, right? So they can be memorized in the form of a mnemonic: cube, T3, MPL. And MPL, I actually remember it with the mnemonic like maple, right? So A and E are silent, and then MPL, and then cube T3. So okay, let's begin. So first step would be the cube. In the cube would be the 5 C's. So 5 C's in the cube would be CBC, then CMP, complete metabolic profile, creatinine phosphokinase, CRP, and chest X-ray, CT scan, and CT chest. So that is in our step ladder in which we are going to go. This is our step number 1 in cube T3 MPL. So in the cube, we are doing the 5 C's. This is our step number 1, the 5 C's. So in the 5 C's, we have CBC, then CRP, then complete metabolic profile, then creatinine phosphokinase and chest X-ray, along with CT chest or CT scan of the head as needed. That makes our C raised to the power 5 component of cube. Next comes the UBP E component, which is step number 2, right? And UBE stands for, first of all, would be the urine analysis, urine culture, and the urine toxicology screen. Then would be the beta HCG for all women along with HbA1c, and then with the E comes the ECG, echo, and ESR. So that's exactly what we are going to do. Let's write all these down over here. For our next step, we're going to do urine analysis, urine culture sensitivity as needed, as well as urine toxicology. That makes our U done. And then we have B for beta HCG along with HbA1c if the patient is like diabetic, and then or we are suspecting some sort of glucose abnormalities. And then for E we have EKG, ESR, and along with echo as needed, right? Okay, so that makes our C5 UB done. And now we are going to move on to like T3 and MAPLE. So this would be our step 3 and our step 4. So our step 3 would be T3, that's our step 3, and MAPLE, that is MP and L, would be our step number 4. So in the T3 we are going to do TSH, troponin, and toxicology screen. TSH, troponin, and toxicology screen. TSH for hypothyroidism, troponin for again cardiac abnormalities, as well as toxicology screen in order to find that the patient is intoxicated in some form. Then we have the final fourth step, the D step, which would be MP and L, and L is here cube over here. So M is for magnesium, Phi is for phosphate or PT, L is for lactate, LDH, and lipid profile. So you can also remember it N1, P2, and L3, right? So M1 is, the M is for magnesium, the P is for phosphate and PT, and the 3 L's are for lipid profile, LDH, and lactate. If you have these in the front of your eyes, or if you have that in the back of your mind, it will be very easy for you to actually order the appropriate test. So let's do a quick review of our steps. Let's begin. So in the cube, first of all, we have C raised to the power 5. This is our step number 1 or step number A. So in the C, we have CBC, then we have CRP, then creatine phosphokinase, and complete metabolic profile along with chest x-ray, CT of the chest or head. Then we have the UBE, which is step number 2, or you can call it step number B, in which you are going to do urine analysis along with urine culture sensitivity or urine toxicology. So you can pick and choose from these according to your patient situation. B beta HCG for all women who are pregnant along with HbA1c, and E is for echo, EKG, as well as ESR as needed. Next come the 3 T's, which is the step number 3 or step number C, which includes T for TSH, T for troponin, and T for toxicology. Then we have M1, P2, L3, and this is step number 4 or step number D, and M for magnesium, P for phosphate, P for PT, L for LDH, L for lactate, and L for lipid profile. So that is our general lab studies that we can memorize in case like we are confused what exactly to do. These are the general studies, and this ABCD was for our emergency orders. Now let's move on to our next orders, which are for surgery, and we will remember this in the form of a mnemonic, which is a nice PT. So here for surgery we just have like 2 sort of like steps for it. Okay, so let's begin. N is for NPO, I is for informed consent, C is for cefazolin, and E is for EKG. And then P and T make PT, APTT, and then type and cross match. Let's quickly review them. Step number 1 is NICE, and step number 2 is PT, in which the N stands for NPO, I stands for informed consent, the C stands for pre-operating antibiotics such as cefazolin, E stands for EKG, and then we have P for PT, APTT, and T for blood typing and cross match. That makes our surgery orders complete. So whenever the patient is undergoing surgery, we are going to order all of these. Then comes the counseling and the screening, and then we are also going to divide our counseling and screening into different groups according to like we are going to make them into like different groups so that we can remember them easily. So first of all is the counsel reassure the patient. counsel patient, reassure the patient, and specifically like advise everyone needs to exercise, right? Once you counsel and reassure, you can also like tell them about exercise as well as the medications, what compliance to the medications and side effects of the medication. So this, you can say that this is the most basic thing that needs to be done for all the patients, because you're going to be prescribing some sort of a drug, therefore the medicine thing, as well as if the patient needs some sort of exercise, and of course everyone needs like reassurance and counseling. Then the next step, this is step number A. Then the next step, that is step number B, is, okay, let's make our step ladder over here as well so that we can, you know, continue. We're going to make 1, 2, 3, and 4 steps. That would be A, B, C, and D. Or we can say 1, 2, 3, 4 steps as well. A1, B2, C3, and D4 steps. Okay, for our counseling and reassurance. Okay, so first step, we've already done it, that we are going to reassure the patient, or we are going to like sort of counsel her regarding her disease, if there's cancer specifically, and then we are going to tell her something about exercise, and then regarding drugs, if there is the compliance of drugs that needs to be done, like for antibiotics, or if there are some adverse effects of the drug, right? So this was step number A, or step number 1. Then the next step is regarding safety. There are some things that need to be safe for the patient, like, and he needs to take care of regarding safety. That would include safe sex, that would include safe driving, which is seat belt, that would include safe drinking, which is alcohol, and that would include safe smoking, so basically no smoking, right? So these are 4 step things that I have combined together in the name of safety, that the patient needs to have safe sex, the patient needs to have safe seat belt, the patient needs to be safe from alcohol and safe from smoking. This is step number B. Then we have step number C, something that we can do inside the hospital. So this safety was all outside the hospital. These were all, the step A was just general advice. Now we have vaccines and screening, something that we will do inside the hospital before we actually send the patient home, that we will give him some shots, or we are going to screen him for certain diseases. That is step number C, right? And then we have step number D, that once the patient is like, he needs to be he needs to be like taken care by other people, like other than us. So where are we going to refer him to? So the places that we can refer him to is, one, like a dietitian who can counsel him that he needs to have low sodium diet, specifically for heart failure, or if there's like he's obese, so any sort of changes in the diet that need to take place. So one is like diet, and you can remember it by referring it to a nutritionist for diet, or dietitian for diet, right? Similarly, if the person is like homeless, he has insurance problems, or he has abuse problems at home, we are going to refer him to a social worker. And similarly, if he has some substance abuse problem, we'll consult substance abuse services. And if he has some public health infectious disease such as HIV or TB, we'll notify the public health department. And always for the kids that have fever, we are going to tell the parents that the kid is advised to not have aspirin because of the risk of like the aspirin causing damage, encephalopathy, as well as hepatic damage to the kid. So this is step number 4, which you can which you can memorize by the name of referral. So 5 types of referral. The patient can be referred for like diet counseling. For example, specifically for heart failure, it would be a low sodium diet, and he can be referred to social services, specifically if the patient is uninsured, he's homeless, or he is experiencing some sort of an abuse. And similarly, he can be referred for substance abuse counseling and rehabilitation. And similarly, besides this, we have notify the public health department if it is HIV or TB. And then we can also advise the parents that they are not going to give any aspirin to the child once the child is at home, because of the risks of causing Reye's syndrome in the kid. Okay, so quick review of the counseling and screening is step number A, which includes like the general counseling as well as like reassurance, exercise, advice regarding the medication side effects, as well as the compliance, right? So this was all regarding, you can like label it as the general counseling. Then step number 2 was regarding safe. 4 things that we have to keep safe, like safe sex, safe driving with the seat belts, and safety regarding alcohol, and safety safety regarding smoking. Then something that we can do with the patient in the hospital, which includes the vaccination and screening, and some of the places that we can refer the patient to, which include like diet management with a nutritionist or dietitian, social services, substance abuse, the public health notification in case of HIV or TB, and no aspirin in case it's a child with fever, so that like he doesn't develop Reye's syndrome. So that concludes our counseling and screening algorithm, and now we'll proceed forward with what we are going to do in case of fever. So always remember, in case of fever, what are our main goals for the diagnosis and what are main goals for the treatment. So we are going to always like divide any case that we are approaching into two parts. Why do we want to do certain things for the diagnosis? Why are we doing these investigations? And what are our goals for the treatment? So whenever we have fever and we don't know the cause, it's very important to like hunt out the cause. And how are we going to hunt out the cause? We can hunt out the cause by looking at the various systems which can generally be causing some sort of an infectious problem. So they include, one is chest, one is blood, one is urine, and of course like some general tests which will tell us that there is some sort of infection or inflammation going on, right? So general along with chest, blood, and urine, that's what we are going to investigate. And in general we have ESR and CRP. In the chest, we have chest x-ray to rule out pneumonia. In blood, we have blood cultures. And in the urine, we have urine culture, urine analysis, along with checking the urine for any sort of illicit drugs, because they can also cause fever sometimes. And the treatment, one specific treatment is Tylenol. And besides that, of course, you're going to treat the cause according to whatever you find out in these tests, right? Then we have SIRS, which is a systemic inflammatory response syndrome. And it is the occurrence of at least two of the following criteria. So you are going to have something from, these are like the three vitals, and along with one WBC count. Any two from amongst these four means that the patient has SIRS. And what you are going to do, then we're going to discuss that, but first you need to be able to diagnose that the patient has SIRS. So remember the values of 36 and 38, or you can remember 96 and 100. 36, 38 or 96 and 100, that's temperature. Anything below 36 or greater than 38, or anything below 96 or greater than 100, that's in the temperature. Then we have the heart rate, for which you are going to memorize 90, 20, and 12. So I remember it like with the step ladder coming down. So that's 90, 20, and 12. And of course, like you can memorize it easily, like what should be 90. 90 is something that should be heart rate, right? Anything greater than 90 in heart rate is one criteria for SIRS. Anything greater than 20, what should be greater than 20? What rate should be greater than 20? Of course, the respiratory rate, right? And then we have 12. What should be greater than like greater than 12? So that's like the WBC count greater than 12 into 10 raised to power 9 per liter. So that makes it like in the form of, again, a step ladder that we have been making. So 36, 38, anything less than 36 or greater than 38, and I think I'm making the arrows wrong. Okay, anything less than 36 or greater than 38, anything less than 96 or greater than 100 or greater than 100. Okay, and then we have 90, 20, and 12. So 90 is going to be the heart rate, and if the heart rate is greater than 90, if the respiratory rate is greater than 20, and if we have the leukocyte count greater than 12 raised to the power 10 into 10 raised to power 9, then that is SIRS. And what are we going to do? Just like we did for the screen for our fever, in this situation, because of SIRS, we are going to first do a pan culture. What is a pan culture? Like the ones that we've already done. That's something regarding we are going to do the blood cultures, then the urine culture, then the sputum culture or the stool culture, according to the situation of the patient, along with the chest x-ray. And we can also do the other two like general tests, which were ESR and CRP, and we are going to give prophylactic antibiotics. So if it's simple fever, until and unless we know the cause, we are not going to prescribe antibiotics. But over here, like if there are some other like signs and symptoms that are telling us what's the particular cause of the fever. But in this situation, since the patient like definitely has the infection that's widespread, we are going to start him empirically on vancomycin and ceftriaxone. Okay, so vanco, ceftriaxone, these are the hard-hitting antibiotics that we are going to use if the patient is suffering from SIRS. Then we have an abscess. So whenever the patient has a collection of pus in any part of the body, first thing that we're going to do, of course, we are going to drain the abscess and do a culture and gram stain, right? So for investigation, we actually need to know whether the antibiotics that we are actually giving to the patient, the organism is actually like susceptible to them and it's not resistant, right? So the abscess needs to get a culture along with a gram stain in order to determine the cause, right? So we are going to determine the cause of the abscess, or we can say the organism, by gram stain and culture, and we are going to do a needle aspiration, needle drainage, and antibiotics as needed. And suppose the patient has neutropenic fever, in which situation the patient has like neutropenia, neutrophils are low, and the patient has fever as well. So we are going to do the fever workup. You remember the fever workup, that we will be dividing it into the different systems that we will be investigating, which is the chest x-ray and then the blood culture. And for the urine, we'll do a urine analysis and urine culture sensitivity or urine toxicology. And then we can also do the ESR and CRP. And as needed, if the patient needs a sputum culture, if the patient needs a stool culture, that can also be done. And then, of course, like again, just like we did it for SIRS, that SIRS in SIRS, since the infection is so already like spread in the entire body, Similarly, in case of like neutropenic fever, since the patient is already neutropenic, we need to give empirical antibiotics, which include anti-pseudomonal over here, which is piperacillin, tazobactam, or cefepime. So he needs to get these antibiotics. And of course, like since the patient is neutropenic, he requires immediate antibiotics, and we are not going to wait for the cultures to come back. So this concludes our discussion on the general things that we need to remember for the CCS cases. And now we are going to begin our discussion on what are the cases from the cardiovascular system that can come and how we are going to approach them. So the first thing that you have to remember is that if a patient is coming with chest pain, what is the differential diagnosis that should be in your mind? So first of all, like we can divide the differential diagnosis, of course, into like two parts. One are the things that are, of course, like pulmonary in nature, and one are the things that are cardiovascular in nature, right? So let's do the cardiovascular things first, since they are lesser, and then we can do the pulmonary things. So what are the cardiovascular things that immediately come to our mind? That you are sitting in an ER and the patient comes acutely with chest pain, you are thinking of course, an acute MI, angina, first of all, right? Then an aortic dissection, and then the third thing related to the heart would be pericarditis. So for cardiovascular, you have CVS, and of course, like CVS has three alphabets, so you have three things, which is aortic dissection, angina, and pericarditis. And then regarding the pulmonary things, what sorts of pulmonary things can a patient present to you in emergency? That would include pneumothorax, pulmonary embolism, or he can also have pneumonia that is causing pruritic chest pain, or tension pneumothorax, or an exacerbation of asthma. And it's always good that whenever you have a chest patient, you consider both possibilities. You're going to work him up for the cardiovascular causes along with the respiratory causes. So it's always good to get a chest x-ray, and even if like you are like, okay, I'm sure it might be an MI, but you're going to rule out the chest or the pulmonary causes as well. Okay, so let's begin with pericarditis. So of course, like we are going to do an EKG, which can show like diffuse ST segment elevations, and then an echo to rule out pericardial effusion. So like these are the basics. Whenever you have a patient with chest pain, you're not going to like go anywhere without doing an EKG or an echo. We've done these like in the general tests as well before, right? And of course, like the trop as well, you've got to rule out in like MI and do the cardiac enzymes as well. And of course, like again, to rule out some respiratory cause, you're going to rule out do a chest x-ray, right? Okay, but you're going to do an echo, but you are not going to order anything invasive like transesophageal echo or needle pericardiocentesis, and you will already order these if the effusion is symptomatic or if it is greater than 2 centimeters. And then of course, like you have to establish the cause of it. So the general causes that you might think regarding pericarditis can be, of course, it can be autoimmune. For that, you can, like as a screening tool, you can order ANA and RF, and similarly it can be uremic pericarditis, so you can order like basic metabolic profile. And it can also be cocaine induced pericarditis, in which situation you can order a toxicology screen, right? So these are the different causes. First of all, we are going to establish the cause with the EKG and echo. And after we have established the cause, we are going to think about the different causes. So we are going to establish the causes after we have established the diagnosis, right? Confirm the diagnosis. So confirm the diagnosis with EKG and echo, and of course, like rule out other respiratory things, and rule out an MI with trop, and rule out with pulmonary cause with chest x-ray, and then establish the causes with like whatever pericarditis causes you can think of at this moment, such as basic metabolic profile, toxicology screen, ANA, and rheumatic and rheumatoid factor. Then comes the treatment. So again, the treatment is also going to be divided into what are the specific treatments and what are the general treatments, right? What are the things that you're going to give to all the patients no matter what, and what are the things that you're going to give specifically if there's any one specific cause. So generally for all patients of pericarditis, you have to give NSAIDs, colchicine, and then PPIs, right? So these are the three things that like you are going to give pain control as well as like decreasing the inflammation or pericardial inflammation. And then you have like if the patient is still refractory after NSAIDs, colchicine, and PPI, the pericarditis is refractory, then you're going to give glucocorticoids. And specifically, if it's a uremic cause, the patient has high BUN and creatinine, then you're going to go ahead and do dialysis. So this was regarding pericarditis. So suppose like the patient has angina, right? So what are the specific things in this situation that you are going to order? So the general things, of course, like that, I'm saying that those are common to all of the patients that are going to come to you with chest pain are ECG and echo and trop. So these are for the cardiovascular causes, and for the respiratory causes, since I'm telling you that the chest pain has these two main things that you have to rule out, you're going to always do a chest x-ray in order to rule out an aortic dissection or pneumothorax, right? So these are the general things. Then there are specific things. If the ECG and the trops are specifically like pointing towards angina, then you have to establish the associated risk factors. Does the patient have high lipids, hyperlipidemia with lipid profile, HbA1c, deranged glucose, brain natriuretic peptide, BNP, along with magnesium. So these are specifically once the ECG and echo and trop are pointing towards a cardiac cause, then you're going to do the establish the associated risk factors, which would be lipid profile, HbA1c, BNP, along with magnesium. Okay, and then we're going to go to the specific treatment. Again, we are going to establish like why are we going through this like specific treatment. We're also going to like divide it into different parts. One is the treatment that you're going to like memorize with a mnemonic, because again, MI, angina, they are so common, so it's best that you actually memorize the treatment with a mnemonic so that you don't forget any of the step, right? And I have memorized it by this mnemonic, which is Monarch Ask Me Anything. Okay, I know it doesn't make a lot of sense, but since I am unable to like recall everything that needs to be done, and R is actually small because R doesn't stand for anything, so it's Monarch and then AMA, Ask Me Anything. Okay, so let's go through it one by one. M, morphine, since the patient is in acute pain. Oxygen, since the patient might have low oxygen saturation, and of course you want to improve the oxygenation to the heart as well if the patient is having angina. And then for N, you have nitroglycerin. A is aspirin, C is clopidogrel, and H is heparin. So let's quickly revise Monarch. M is morphine, O is oxygen, A is aspirin, and along with aspirin, of course, you can memorize like clopidogrel. N is nitroglycerin, and then C is clopidogrel, and H is heparin. Then we have AMA, Ask Me Anything, right? So specifically for the control of angina, like you're going to give metoprolol, which is going to decrease the, of course, the cardiac contractility and the oxygen demand. So that is for M. And with A and A, if the patient has TIMI index greater than 2, then like if the patient on angiography has his multiple vessels that are blocked, has triple vessel disease or two vessel disease, then you're going to do it after angiography. You can do an angioplasty and atorvastatin if the patient is hyperlipidemia. So that's AMA. So the basic mnemonic for the angina would be Monarch AMA, where the M stands for morphine, O is for oxygen, N is for nitroglycerin. The A is for aspirin, C is for clopidogrel, H is for heparin, and in the AMA, A is for atorvastatin, M is for metoprolol, and A is for angioplasty. And of course, before doing angioplasty, you are going to do PTA, PTT, and INR, and we are not going to put this in any mnemonic. Of course, if it's a cardiology case, consult cardiology. If it's a pulmonology case, consult pulmonology, right? And regarding the prevention, next, if the patient is hypertensive, we are going to give him ARBs, and of course like a low sodium diet, so that like we don't fluid overload the heart, right? Okay, then if this patient specifically has right ventricular MI, what's the goal of like the right ventricular MI? Again, it's a type of angina, so what are the goals in your diagnosis? So again, we're going to divide the diagnosis just like we did previously into like the general tests, which we are going to do to establish the cause, and then the specific tests for the associated risk factors. for the MI or the angina, right? And the general test, I told you that for every patient who has chest pain, you have to get an ECG done, and then an echo done, and then like the cardiac enzymes and troponin, and then we have the chest x-ray. And for the specific associated causes, you're going to do a lipid profile in order to look for hyperlipidemia, HbA1c, and to look for the glucose control. And then we have basic metabolic brain natriuretic peptide along with magnesium, specifically for the cardiac causes. So these are like all the same that we did over here. So right ventricular MI is the same for angina. Then regarding the treatment, again I had like difficulty memorizing the treatment, so I made, just like I made a mnemonic for the acute MI, I made a mnemonic for the right ventricular like MI as well, because you cannot, like, this is an emergency situation, you cannot like miss any of the things, right? So I made a mnemonic of NBME fashion, right? So NBME is like a cross. You are not going to give NBME, right? So NBME, and NBME we have N for nitroglycerin, B for beta blocker, and M for morphine. These are the pains specifically you're going to avoid in right heart failure, since the patient is like, the right heart is already compromised. If you give a beta blocker or nitroglycerin or morphine, it can actually tax the right heart, right? So the cross includes nitroglycerin, beta blocker, and morphine. You're not going to give these three. So what are you going to give instead? You're going to give FASH or fashion instead, right? So the ION is silent, but the FASH is here. You're going to give fluids in order to like support the right heart. Going to give aspirin, clopidogrel, which are like the antiplatelet agents, S for the statin, and H for the heparin. So three things you're not going to give: nitroglycerin and the beta blockers, as well as the morphine. And four things that you're actually going to give, which are FASH, which are fluids. A is for aspirin, clopidogrel, S is for statin, and H is for heparin. And of course you're going to do a cardiology consult, because this is a cardiology case. Okay, then we have aortic dissection. Again, the general test would be the same, beginning from like the chest x-ray, ECG, echo, and then specifically chest x-ray is going to show to you the widening of the mediastinum. That puts you in the position, okay, this is probably aortic dissection. Then you do this tests that are specific. So in the general, chest x-ray to establish the diagnosis, and then specific to further, sort of like determine the extent of the dissection. That would include the transesophageal echo. If the patient is unstable, right, you're not going to send him for CT angio and then he becomes unstable and dies over there. Rather, you're going to do the transesophageal echo right here in the emergency department, the ICU. And if the patient is stable, then you can actually send him for CT angio, right? So some general cause, the general test, that's the chest x-ray, and then the specific test in order to establish the extent of the dissection. That would include transesophageal echo and CT angio. Now, coming to the treatment, we have different goals for the treatment. So before this, for the right ventricular MI and the angina, we were just memorizing everything. And of course, it's not possible to like make mnemonics for everything. So those two emergency situations, I feel like are too acute, and I've found it difficult to like memorize them by goals. But for aortic dissection, like if you think that the patient has aortic dissection, you yourself can establish goals, right? So of course, like the patient is in too much pain, right? So he needs morphine, that's a given. And similarly, the patient's blood pressure, the dissection occurs because of very high blood pressure, right? So you need to control the blood pressure. So for blood pressure, you're going to give labetalol, nitroglycerin, or nitroprusside, right? And then of course you have to fix the dissection, so you have to give surgery orders, the pre-surgical orders, and consult the cardiothoracic surgery. And one thing very important to remember for A's for aortic dissection is that you do not have to give aspirin. So it's very important that you establish the diagnosis that it's not MI or right ventricular MI, rather it's like aortic dissection. In aortic dissection, you do not have to give aspirin, whereas your goals are to control blood pressure with labetalol, nitroprusside, or nitroglycerin, and then to control pain with morphine, and fix the patient's dissection with the pre-surgical orders, as well as cardiothoracic surgery consult. And of course, you can also do a cardiology consult, but cardiothoracic surgery consult would actually do. The next off, we have heart failure, since the patient might be having like pulmonary symptoms or peripheral edema. So then it will like give you a clue that it's heart failure. And of course, like you're going to do all the cardiac exam along with the test that we already mentioned, that the cardiac tests along with the pulmonary tests of like chest x-ray, so EKG, echo, trop, and along with all the basic tests you're gonna do, right? And for the treatment, again, what's the goal? The patient is in heart failure, his heart is not working properly, and of course you already already know that the patient might as well be in a state of fluid overload. So you need to support his heart. And first of all, remove the extra fluid that's present, right? Fluid unload him. That's furosemide. Then like put less load on his heart if you can't like actually make the heart better. So you want to put less load on the heart so the heart can contract better with whatever energy it has, and therefore you're going to give nitroglycerin to decrease the pleural. And third thing, you have to monitor the fluid status. You don't want him to become like too dehydrated or overhydrated, be in fluid overload, or too little fluid as well as. So that's why you have to do an input output monitoring for the heart failure. And regarding the preventive, of course, you don't want him to go again into a state of fluid overload, therefore sodium diet restriction and the drugs that have mortality benefit in cases of like heart failure, which include like ACE inhibitors or carvedilol, they can be given, and pneumococcal vaccine for the prevention of pneumonia. Okay, and then there's a step ladder that I made for the drugs that can be given in heart failure, depending upon whether it is like mild or tone moderate or severe. And I remember it with the mnemonic of lab DS, right? So for DS, you can remember it like with DSLR probably, or DS, like in any way that you can remember DS, but it's lab DS. So first of all, if the patient has mild heart failure, you're going to go with everything that's low. So you're going to keep down and lower his activity level along with his sodium level. So low sodium and low activity is step number 1. Number 2 in the L, so it's basically L square, are the loop diuretics. So you're going to fluid unload him, specifically if it is his volume overloaded and has pulmonary congestion and severe dyspnea. Then we move to the A component, right? Where the A component is ACE inhibitors. As I told you, that ACE inhibitors have mortality benefit in cases of congestive heart failure. So from low sodium, low activity to loop diuretics and then ACE inhibitors. Then we have B for beta blockers in the lab, right? So beta blockers again like carvedilol that have mortality benefit in patients of congestive heart failure. And then we have D and S with digoxin followed by spironolactone. So that's the step-up pattern. Let's revise it quickly. Lab DS. L for a low sodium diet and low activity, L for loop diuretics, A for ACE inhibitors, B for beta blockers, and D for digoxin, and S for spironolactone. Next comes atrial fibrillation. Again, the basic cardiology workup that we've already done with ECG, echo, along with chest X-ray and the cardiac enzymes troponin, along with establishing the specific risk factors such as HbA1c, lipid, basic metabolic profile, magnesium. So we are going to do all of these as we have done for the previous tests, right? But of course, the ECG is going to show you that the patient has atrial fibrillation. Therefore, like, what are the goals of treatment? What do you want to treat in this particular patient? Of course, first of all, your goal is rate control, right? And if of course the rate control fails, then you can go to rhythm control, right? So you're going to do rate control with either a beta blocker or if it fails, you're going to do it with a calcium channel blocker such as verapamil. So the metoprolol is the preferred agent for rate control first of all, right? Then of course, like you know that with atrial fibrillation there are high chances that the patient can form a sort of a clot in the heart, right? And the clot can actually like dislodge and embolize to other places. Therefore you have to anticoagulate him. One is the rate control. One goal is the rate control. Then the second goal is to anticoagulate with either rivaroxaban or warfarin. And of course, before administering rivaroxaban or warfarin, you need to do a baseline PTA, PTT, and of course, it's a cardiology case. Therefore, you need to do a cardiology consult. Then we have claudication. So suppose the patient has claudications, and along with claudication, the patient also has diabetes. So in the diagnosis, the things that you like need to do specifically, again, like we have done for all the cardiovascular cases up until now, the goals of these the investigations is to establish the risk factors that the patient have. What were the risk factors? Now this is not a cardiac thing, right? The patient has claudications, but the risk factors are same as for cardiovascular diseases such as lipid profile in HbA1c. Then you're going to establish the diagnosis. You're going to establish the diagnosis with the Doppler ultrasound of the lower extremities. And then if this patient specifically, they were saying that the patient has diabetes, so looking for the diabetes complications such as the presence of microalbumin in the urine, which can actually like indicate that the patient's kidneys are actually becoming involved in diabetic nephropathy, right? Okay. And the treatment is simply SAM, right? And we are going to, like, that's a mnemonic that just came automatically. But even if like we focus on the goals of care, then that would be of course the diabetes control, the hyperlipidemia control, and the antiplatelet, or like preventing the atherosclerosis from happening control, right? So and of course if he has like high blood pressure issues, of course then we're going to give ACE inhibitor lisinopril as well, right? But other than that, so then it would be A square, right? So the S would be for statin, the A would be for aspirin, and the M would be for metformin, along with of course like blood pressure control with ACE inhibitors. And in prevention, you can do an exercise program, or like the smoking cessation, since the patient might be a smoker and the smoking might be exacerbating his claudications, and exercise is going to improve the blood flow in his legs. Then we have hypertensive emergency. If the patient has like severe hypertension, the first thing that you have to like rule out, of course in addition to the other causes, and if the patient has chest symptoms, then of course you're going to do the chest workup as well. But if the patient has hypertension emergency, you can diagnose it with like a CT scan of the head and chest x-ray specifically to see like the extent of cardiopulmonary damage and pulmonary edema, and CT head of course to rule out some sort of intracranial bleed that is caused by the extremely high blood pressure. And in the treatment, now what are your goals? What do you want to do? So in this situation, like for the specifics, for the generals, you can refer to the general tests that have to be done, but these are the specific tests that you have to do regarding the head, and this is regarding the chest, since you are concerned about these two the most to be damaged because of the hypertensive emergency. Now the goals of treatment, of course, first of all, it's hypertensive emergency. You have to control the blood pressure. Number two, of course, like the patient might be in a state of fluid overload, unload, right? So fluid status monitoring with input-output monitoring. And then regarding the patient's general support with making the patient NPO and giving him ondansetron for the nausea. So these are the three main things that you have to control in hypertensive emergency, that include blood pressure control with hydralazine or labetalol, the fluid control with input-output monitoring, and this supportive treatment with nilparol or ondansetron for nausea. And then of course, like hypertensive emergency just doesn't need to be just elevated blood pressure, but it can manifest in a large number of cases. If the heart is involved, it can cause acute MI. If the brain is involved, it can cause hypertensive encephalopathy or intracranial hemorrhage. Similarly, if the aorta is involved, it can cause dissecting aortic aneurysm. So it can basically have, like, you can divide it. It can basically have CVS manifestations such as acute MI and dissecting aneurysm. It can have CNS manifestations such as encephalopathy or intracranial bleed. It can have renal manifestations such as acute renal failure, and it can have pulmonary manifestations such as flash pulmonary edema. So depending upon the presentation along with the hypertensive emergency, you are going to order the relevant investigations, and then you're going to treat the patient accordingly as well. Next up, we have heart block. So again, for heart block, the general things, if the patient has like the EKG and the echo, they are the same, but some things that need to be specifically is to rule out the cause. So in order to establish the cause, you're going to do again the same things such as ECG and echo, but to find out what's the specific thing that's causing the heart block, you're going to do a Lyme serology, because of course like Lyme's disease is one of the causes of like heart block, and lipid profile again to find the associated risk factors, right? And then in the treatment, of course, it's a heart block, so you have to make the heart work again, which is with the temporary pacemaker, and then ultimately with the permanent pacemaker. And since it's a cardiology case, you have to consult cardiology. Next up, we have newly developed fever and murmur, which of course points out to infective endocarditis until proven otherwise. The basic step you are going to do, but what is something that's specific, since it's heart and it's infected, right? So you want to visualize the heart for vegetations, and you want to establish the infection, right? So you have to peek into the heart, right, for the vegetations. That's one goal of diagnosis, and the other goal of diagnosis is to establish the investigation in infection, in addition of course to the basic set, right? So that would be echo and blood culture. And what's the goal of treatment? What do you want to do in case of infective endocarditis? 2-3 things, right? One, you want the patient's infection to go away, right? So for infection control, infection treatment, you're going to give him vancomycin plus gentamicin, right? Vanco plus gent is the combination used to infectious endocarditis. And of course, you're going to consult if the patient might have such big vegetation that they may need surgery. So then cardiothoracic surgery consult. And since the patient is having an infectious disease, so consult infectious diseases. Next up, we have cardiac tamponade. So in case of cardiac tamponade, of course, like the general chest workup is going to be done, and specifically you are going to do a chest x-ray and a fast scan. Next up, we have the treatment of the cardiac tamponade. Now again, the treatment goals can be divided into like different parts. So one would be the supportive treatment for the airway, breathing, circulation, right? So this is the breathing part and this is the circulation part. So breathing support with oxygen, since the patient might be hemodynamically unstable, and the fluid support if the patient has hypotension. So then circulatory support with fluids. And then of course you have to remove the cause, right? Treat the cause, and then treat the cause with pericardiocentesis. And since the patient might need cardiothoracic surgery, so therefore cardiothoracic surgery consult. And if the patient is bleeding so rapidly around the heart that he is becoming hypotensive, you might need to replace the blood with type and cross match. So for every case, you just have to like think about, okay, what is my goal? If the patient has cardiac tamponade, what is specific test that I can do in order to establish the cause and in order to confirm the diagnosis of cardiac tamponade. So in order to confirm, just do a chest x-ray and a fast scan. That's enough to show a globular heart, and the fast scan to show the rapidly accumulating blood around the heart. And in the treatment, first of all, stabilize the patient with oxygen as well as the IV fluids if he is hypotensive, and then remove the excess fluid with pericardiocentesis. And if he's becoming still hypotensive despite the fluids, arrange for type and cross match and transfuse the blood, and consult cardiothoracic surgery if he needs surgery in order to repair his heart issue. Right? And that concludes our part 1 of CCS cases review. This was a comprehensive review of all the general things that we need to do for the CCS cases, the things that we need to take into account for in the case, what physical exam we need to do for if the patient is unstable and stable. Then we went through the A, B, C, D of the emergency orders, and then the general lab studies we memorized with A, B, C, D, divided it into A, B, C, D with C5, UB, and then G3 and MAPLE, MV, P2, and L3, and then we went through the surgery steps, which was A and B, NICE, PT. Then we did the counseling and screening. So these are all the general things, right? Then we did the counseling and screening with A, B, C, D, in which we did the general counseling, the safety measures, the hospital things that we can do, and the referral things that we can do. Then we went and saw the fever, SIRS, abscess, neutropenic fever. These are the general things. And then we have covered the CVS. And we're going to continue the next systems in our next video. If you like this content, please like, subscribe, and comment, and wait for our next CCS cases review. That's it. Bye.